Hi, everybody. It's my pleasure to introduce Dr. Julie Buring, who is Senior Epidemiologist in the Department of Preventive Medicine at the Brigham and Professor of Medicine at Harvard Medical School. I think that Julie knows this because I say it every year, but I think that the farther I go in my career, the more I realize how important the class that I took with her when I was a first-year medical student was. And certainly in these times of COVID, when we are faced with making a lot of decisions based on epidemiology and statistics, and faced with friends, family, and colleagues who've all become expert epidemiologists, this talk takes on even more importance. So I look forward to hearing Julie's Biostatistics Board review. Thank you.
Thank you. Good morning, everybody. I'm really pleased to be here today to do this Biostatistics Board review. And the really nice thing about it is going through the questions that I've seen, there's really only a finite number of topics that are considered to be, particularly important, and they're related to screening, sensitivity, specificity, predictive value, and particular kinds of bias that need to be considered, lead time bias. They're related to measuring the data with respect to frequency, prevalence, or incidence, and with association, relative and absolute measures of association, and then the interpretation of the data in terms of the types of studies we encounter in the clinical or public health literature, and how do we assess whether we have a valid statistical association in that study? How do we take into account chance, bias, and confounding? So what I'd like to do in this talk is to put up a scenario related to each one of these, and then review the principles of epidemiology and biostatistics that are directly relevant to the question, which would allow us to know what the appropriate answer would be. So let me start with screening, and here's the scenario. Let's say we have 100 women over the age of 50 who received a mammogram at a mobile breast cancer screening unit. 27 of them had findings suspicious for malignancy on the mammogram. They went on to do a biopsy, and 19 of these women were confirmed as having breast cancer by biopsy, so true positives. One woman had a negative mammogram, but in the subsequent years, she developed breast cancer and is assumed this is a failure of the screening program. She had the disease at the time of the screening, so that's a false negative. What's the sensitivity of the mammogram, the specificity, and the predictive value of a positive test? Well, the first thing that we need to do is look at a 2x2 table. In particular, the relationship between the screening test and the truth, the disease status by whatever measure we assess it. Here, let's say biopsy. So A is the number of people who tested positive on the mammogram, and after the biopsy, they were said to have breast cancer. B, the number of people positive on the mammography, but after the biopsy, they were said not to have breast cancer. C, the number of people who are negative on the mammogram, but they developed breast cancer within the next 1 year period of time by symptoms. So they are felt to be a failure of the screening. And D, the number of people who tested negative and in fact did not have breast cancer. So we have A plus B people who had the mammogram, C plus D who did not, A plus C who in fact had breast cancer, B plus D not. Sensitivity and specificity are measures of the validity of the screening test. In other words, does it do what it's supposed to do? If the person has breast cancer, do they test positive? Sensitivity. If the person does not have breast cancer, does the screening test negative? Specificity. And in addition, there's another measure that we look at, which is predictive value, where we turn the whole thing on its head and say, I don't care among those who are diseased and non-diseased. I want to think about it as a person. If I test positive on the mammogram, what is the probability that in fact I have breast cancer? Predictive value positive and predictive value negative. If I test negative on the mammogram, what is the probability that I in fact do not have breast cancer? So switching this now to our example, we had 100 people with breast cancer, 27 of whom tested positive on the mammogram. and of those, 19 in fact had breast cancer. 73 tested negative on the mammogram. One of them was assumed to have breast cancer at the time the mammogram was given. Total of 20 breast cancer cases and 80 without breast cancer. So the sensitivity would be, of those with breast cancer, 20, 19 of them tested, with those 19 of them tested positive on the mammogram, 95%. And specificity, of those without breast cancer, 80, 72 of them tested negative on the screening test, or 90%. And then let's look at predictive value. Among those who tested positive on the mammogram, 27, 19 of them actually had breast cancer, or 70%. And of those who tested negative, 73, 72 of them tested negative, did not have the disease, or 99%. Well, can we change those numbers? Can we do anything about sensitivity, specificity, and predictive value? Well, what about the following? If a Mantoux tuberculosis screening program in a high-risk population, the criterion for a positive test on the screening test was defined as 10 millimeters of induration. Let's say the guidelines change. Let's say the criterion for a positive test is now defined lower, as only 5 millimeters of induration. What will that do for the sensitivity? What will that do for the specificity? What will that do for the positive predictive value? What will it do for the false positives? And what will it do for the false negatives? Well, that criterion of positivity is the important thing. It influences both the sensitivity and specificity of the screening test. In particular, we all know that on any test that has a range of values, we know when people are clearly abnormal, we know when people are clearly normal, and there's a line, a criterion of positivity at some point where we say, if the person has up to that line, we're going to consider them normal. If they have over that line, we're going to consider them to be abnormal. And we put that line down based on our clinical knowledge or based on tradition. If the criterion of positivity goes lower, so it doesn't take much at all for us to say on the screening test that someone is abnormal, then that will increase the sensitivity. We're going to pick up all of our cases, but we're also going to pick up people who end up not having the disease. We put them through the healthcare system. So it's going to increase the sensitivity, decrease the specificity. If we up the criterion of positivity, if it takes a tremendous amount for the screening test to say that you're abnormal, then we're going to miss some cases. So we're going to decrease the sensitivity, but everyone we put through that process is in fact going to be someone we care about. So we're going to increase specificity. The predictive value positive is affected by both sensitivity and specificity, but it's really increased mainly by increasing the prevalence in the underlying disease population. In other words, we are more likely, if we test positive, to have the disease if there is more disease in our population. So as you screen a higher risk group, the predictive value positive, the likelihood that you have the disease if you test positive, will increase. So what happens to our question? If the positive test has a lower criterion of positivity, doesn't take as much for us to say that it's positive, then the sensitivity will increase, the specificity will decrease, it won't too much about predictive value positive, the false positives and the false negatives will change because they're related to the sensitivity and specificity. False positives will increase, false negatives will decrease. So now we know how to sort of measure the metrics of a screening test, but how about interpreting it? And there's one bias in particular that we need to be aware of, and it's the lead time bias. So here's a scenario. A randomized trial was conducted to evaluate the effectiveness of a new screening program for colon cancer. We have a group of patients whose cancers were detected by the screening program. Their average age at diagnosis then was 54 years. Their average age at death was 60 years. So they reported an average survival from diagnosis by screen to death of 6 years. Then we had those whose cancers were detected by clinical symptoms. Their average age at diagnosis was 56 years. Their average age at death was 60 years. So average survival from diagnosis by symptoms to death was 4 years. The investigators reported a statistically significant 2-year increase in survival from colon cancer that was associated by the screening. 6 years for the screen, 4 years for the clinical symptoms. Why is this a mistaken conclusion? Because both groups died at age 60. Neither group lived longer than the other group, but the screening group lived till age 60, knowing about their cancer 2 years more than the symptom group did. So they knew about it for 2 years more, but they didn't live for 2 more years over the age of 60. So just to look at this, in any screening program, we test asymptomatic people. So by definition, on the day you did the screen, they would not have been diagnosed by clinical symptoms. They didn't have any. So lead time is the amount of time by which the diagnosis is advanced because they came in for your screening program rather than waiting for symptoms to develop. So lead time is the name of that time by which the diagnosis is advanced. The lead time was 54 years on average for the screen, 56 years for symptoms, so a 2-year lead time in their knowledge of the disease, but they all died at age 60. So it is incorrect to say there's a 2-year increase in survival. It's just advancing the diagnosis by 2 years. So the problem is lead time bias, and the way to take care of it is just look at the death rates by screened, among those identified by screened, among those identified by clinical symptoms, and just look at the colon cancer specific mortality at age 60. And we will see that there's no difference between them. So now we need to go back and we sort of measured the metrics for screening, but now let's look at the metrics for disease frequency or disease association. So measuring our data. The measures of disease frequency are going to be two simple ones, prevalence and incidence. How do they relate to each other? The measures of association will be a relative measure and an absolute measure. And how do they relate to each other? The difference between prevalence and incidence is really very simple. Prevalence tells you what is happening in your population at a point in time. If I went out there today, what would I see? The number of existing cases at that point of time divided by the total population. Incidence measures give you development. They talk about the number of new cases that are occurring during a period of time, divided by the population at risk of being a new case of the outcome. You can do prevalence and incidence for your whole population or those at risk, or you can do it category specific. So sex specific prevalence or incidence, age specific prevalence or incidence. So let's say that the prevalence of AIDS in the United States in 2020 is seen to be greater than in 1995, which was the era pre-HAART, pre-highly active retroviral therapy. This could be due to what? Could it be due to a change in the incidence rate? Could it be a change in the duration of the disease, or both? So the prevalence, the proportion of the population that has the disease at a point in time, prevalence, depends on the rate at which the disease is developing, which is incidence, as well as the duration of the disease from onset to termination, where termination could be death, termination could be cure. What's the prognosis? What's the duration of the disease? And under steady state, meaning no new treatment has come out, no new epidemic is happening, The prevalence equals the incidence times the duration. So when we talk about duration, though, when we have a drug which improves survival, they don't get cured, but they don't die as much, then that extends the duration. And that means we're going to see more people with the disease. So a change in prevalence can reflect a change in incidence, a change in duration, or both a change in incidence as well as a change in duration. And the main thing for AIDS is not that it is increased incidence particularly, but because with the new drugs, the duration of the disease has extended. So at any point in time, more people are existing with AIDS than previously. Now let's look at some association. The table below gives the annual mortality rates from lung cancer and from coronary heart disease among cigarette smokers and non-smokers in a cohort study of British male physicians. So in this slide, what we're going to see is the annual mortality rates per 100,000. We'll see them for lung cancer and coronary heart disease, and we'll see them among cigarette smokers, among non-smokers. So this table says among lung cancer, cigarette smokers have an annual mortality rate of 100 of lung cancer of 140 out of 100,000, and non-smokers will have it only 10 out of 100,000, and 669 per 100,000 among the smokers for heart disease, and 413 for coronary heart disease among the non-smokers. Now, from there, we could do incidence rates without any problem. The rate of development, 140 over 100,000 of the outcome among the exposed group, and the incidence among the non-exposed group, 2 out of 100,000. So, but we still have two numbers. So wouldn't it be nice if we could do one number that tells us the association between the exposure, cigarette smoking, and the outcome, which is lung cancer or coronary heart disease? And there's two ways to do that association. One is to just take those incidence rates and divide them. It's the incidence in the exposed group divided by the incidence in the non-exposed group. And that gives you a measure of the strength of the association. How much more likely is it that someone in the exposed group will get the outcome compared to the non-exposed group? And if there's no association between smoking and lung cancer, then those two incidence rates will be the same. When you divide two numbers that are the same, you get 1. So relative risk equals 1 is the null value of no association between smoking and lung cancer. Then, though, what if I don't want to see it on a relative scale, how much more likely a group is than the other? I want actual number of cases. I want to know the difference between those who smoked and those who didn't smoke. So I can look at how many actual cases of lung cancer in the smoking group are due to the fact that they smoke. And that's going to measure the public health impact among the exposed. So we're going to do a rate difference or an attributable rate among the smokers, among the exposed, and just subtract. The attributable risk in the exposed is the incidence in the exposed minus the incidence in the non-exposed. And the reason that formula works is because if you wiped out smoking today, you'd still have some lung cancer. And the lung cancer you would have was the incidence among the non-exposed. So let's take the incidence in the exposed, subtract off the amount we'd see anyhow, the incidence in the non-exposed. And then we would have how many cases among the exposed are due to the exposure, or the measure of public health impact, eliminating lung cancer among the smokers, among the exposed group. If there's no association, when you subtract them, it's going to be 0. So that's the null value of no association. So let's go ahead and calculate it. We have for smoking, the incidence in the exposed divided by the incidence in the non-exposed. 140 over 100,000 over 10 out of 100,000, or 14. That those who smoke have 14 times the rate of dying from lung cancer as non-smokers do. And in coronary heart disease, incidence in the exposed, 69 over 100,000, divided by 413 over 100,000, or 1.6. So those who smoke have 1.6 times the rate of dying from coronary heart disease compared to non-smokers. And since the null value, no association, is 1.0, it is commonly reported as 1.6 times the rate, or a 60% increased rate of dying from coronary heart disease. Now let's subtract them. The attributable risk among the exposed is 140 over 100,000 minus 10 out of 100,000, or 130 out of 100,000 smokers, meaning that given that smoking causes lung cancer, so if you eliminated it, it would make a difference. For every 100,000 smokers, 130 cases of lung cancer are due to the fact that they smoked, or could be eliminated if smoking were eliminated. Public health impact. And for heart disease, 669 over 100,000 minus 413 over 100,000, or 256 over 100,000 smokers. Again, assuming smoking causes heart disease, for every 100,000 smokers, I could eliminate 256 deaths from coronary heart disease among those 100,000 smokers if I eliminated smoking, or they're due to their smoking. So how do we interpret these? Based on these data, do you think that smoking is a stronger risk factor for lung cancer or coronary heart disease mortality? And what do we look at? Well, we said the strength of the association is going to be a relative measure. So we're going to look at the relative rate. And what we're going to remember is that the relative rate of lung cancer among smokers was 13. And the relative rate of lung cancer of heart disease among smokers was 1.6. So the size of the 13 means that for lung cancer, smoking is a huge risk factor. In the etiologic web, understanding lung cancer, smoking is a huge one. For coronary heart disease, 1.6, it's still a risk factor. It's a 60% increased risk, but there must be a lot of other risk factors for coronary heart disease because it's not big enough to be driving the etiology of coronary heart disease. So is smoking a stronger risk factor for lung cancer or coronary heart disease? Lung cancer, since the relative risk for lung cancer is greater than for heart disease. And if smoking were eliminated, could more deaths be eliminated among smokers or lung cancer? What do we look at? Well, we're going to look at the attributable values because that's how much could be eliminated if the exposure were eliminated. And let's think it through for just a second. Heart disease is so much more common than lung cancer. So even a 60% increased risk of a very common disease will actually affect more people than a big risk among a rarer disease. So coronary heart disease was 256 out of 100,000. Lung cancer was only 130 out of 100,000 because it's just a rarer disease. And so coronary heart disease will be more affected since the baseline risk of heart disease is so much higher than the baseline risk of lung cancer. So even a smaller increased risk of a very common disease will affect more people than a big increased risk of a rarer disease. And one more thing about measures of association. Let's look at a randomized trial for just 1 second. It's a trial of pravastatin versus placebo among 4159 people. 2081 were assigned to pravastatin, 2078 were assigned to placebo. Among the 2081 on pravastatin, 212 had the outcome of non-fatal MI or death from coronary heart disease, and 274 did among the placebo group. So if we do strength of the association, it's 212 over 2081 divided by 274 out of 2078, or 0.77. That's less than 1. The null value. So it means that those on pravastatin had less risk of the outcome than those on placebo. And in fact, they had 77% of the risk, or excuse me, one typo on the slide, or a 23% lower risk. I subtracted that from 1 or 100%, and I just missed a typo when I did it. So 77.77 times the risk, or a 23% lower risk. And we subtract the 212 over 2081 minus 274 or 2078. And it's a minus, meaning that the exposed group did better, 0.03. So that means for every one of the outcomes in the placebo group, for every 100 of the outcomes in the placebo group, 3 of them could have been prevented if they had been taking pravastatin, assuming causality. So the measure that you more commonly see related to this is the number needed to treat, which is 1 over that attributable risk among the exposed, 1 over 0.03 or 33, which is interpreted that we would need to treat 33 patients over 5 years, which is the duration of the follow-up in the trial, in order to prevent 1 non-fatal MI or coronary heart disease death. This is often used to put in now, along with side effects, along with differences in cost, differences in the feasibility of getting the drug to people, in terms of understanding what you would have to do to have an impact on the outcome. All right, now let's look at interpretation of the data. Let's look at some types of studies that you're going to see in clinical or public health investigations. And then how do we figure out whether that study gave us a valid statistical association or not? Well, just to remember, every one of our studies now has measures of exposure, at least yes or no, and the outcome, again, at least binary, yes or no. And the difference between the 2 epidemiologic study designs of case control or cohort just depends on how you bring the people into the study. So if I do easy example, smoking and lung cancer, if I bring them in on the outcome, so I have cases of those with lung cancer, controls with those without lung cancer, and I go back and assess whether they smoked or not in the past, that's going to be a case control study selecting people on the basis of their outcome. In a cohort study, I just flip it the other way. I start with bringing people into the study on the basis of their exposure. Do they smoke or not? Follow them up for the outcome. Did they have heart disease or not? And so that's a cohort study, exposed, non-exposed, follow them up for the outcome. Now let's go to a clinical trial. Looks a lot like a cohort study. You start with the exposure. They do have the exposure, do not have the exposure, follow them up for the outcome. But the big difference is that in both case control and cohort studies, they're observational. We, the investigators, do not in any way alter, affect, recommend whether they're going to get the exposure or not. We simply record whether they had the exposure or not, record whether they had the disease or not. In a clinical trial, the investigator actually allocates the exposure. Now, obviously, we could never do that for smoking and lung cancer. You never can allocate harm so that you can figure out what exactly happens to lung cancer or not. But we certainly can do potential benefit. And that could be anything from different ways of stopping smoking. It could be a drug, it could be it could be a therapy, it could be both, and see whether that differs with respect to lung cancer as well as their stopping patterns. But the key here is that the investigator actually allocates it. And then a cross-sectional survey, something like the Framingham Heart Study, where you just go in, take thousands of people, give them a questionnaire at one point in time. The important hallmark feature is that you're asking whether they smoke right now and whether they have lung cancer right now. So there's no time sequence. You don't ask about exposure in the past and then subsequent risk of development of the outcome. You just do a snapshot, figure out whether they're exposed or not and their outcome or not. And sometimes you will find you cannot use that because it will have no time sequence. I don't know whether my smoking reflected my past smoking, therefore it's a risk factor, or whether it's reverse causation, and that the fact that I can't breathe, I've got shortness of breath, I've got pain, chest pain, is in fact affecting whether I'm smoking right now. I did in the past, but I'm not doing it right now because of the symptoms of the outcome. And I can't always differentiate but using those two. So let's go ahead and give a couple examples. The association between low birth weight and maternal smoking during pregnancy was studied by obtaining smoking histories from women at the time of their first prenatal visits and comparing subsequent birth weights among women with various smoking histories. So what kind of study is going to be? The first thing that we need to do is figure out what the exposure is and what the outcome is. So in this case, the exposure is smoking status at the time of their first prenatal visit, and you're either exposed or not. And then the outcome is going to be subsequent birth weight of your baby. So the only study design that is observational, where we take those that are exposed or not exposed, smoking during their pregnancy, follow them for the outcome, is going to be a cohort study. But now let's say somebody wanted to do a case control study. So that study was undertaken to evaluate the same relationship, maternal smoking during pregnancy and low birth weight. But now it's case control. That means we're bringing mothers in of low birth weight babies, cases, and normal weight babies, which will be controls. And then we must be going back and looking at the exposure during the pregnancy. And in fact, that's just what's happening. 350 mothers of low birth weight babies, 400 mothers of normal weight babies were interviewed. Of the mothers of low birth weight babies, 200 reporting smoking during the pregnancy, while 200 of the mothers of normal weight babies also reported such a history. What's the magnitude of the association? And is it a valid association or not, given that study design? So we make our 2x2 table. 350 mothers of low birth weight babies, 200 of whom smoked during their pregnancy, 400 mothers of normal weight babies, of whom 200 also smoked during their pregnancy. And in a case control study, we use another measure of association because we can't get incidence rates. In a case control study, nobody is developing the outcome. They come into the study with the outcome, no development. So we look at the odds ratio, which is, if you look up at the slide for a second, is the cross product ratio, A times D divided by B times C. So AD over BC, which in our example would be 200 times 200 divided by 200 times 150, or 1.3, that women who smoke during their pregnancy have 1.3 times the risk of having a low birth weight baby. Now let's see whether that's valid or not. And there's three alternative explanations that we're going to look at for internal validity. Eliminate the role of chance, of bias, of confounding. And this is internal validity. Another term you will hear is external validity, but most times people will call that the generalizability of the results in the study to a broader population. So chance is the role of sampling variability, test of significance, you do a p-value. Bias, any source of systematic error, not random error, systematic error in the determination of the association. And confounding, a mixture of effects between the association you think you're looking at and a third variable, which can be responsible in part or totally for the association that you see. So let's look at each one. In comparing the association between the two groups, an odds ratio of 1.3, the p-value is found to be 0.2. Now let's remember what it is that means. The p-value is the probability that the observed data, or data more extreme, would occur by chance alone, given that the null hypothesis is true, that there really is no association between the exposure and the outcome. By convention, if P is less than or equal to 0.05, so less than or equal to 1 out of 20 times, would I see my data by chance alone? Then we say that it's unlikely that there's no association. We reject the null hypothesis. We say the association is statistically significant at the 0.05 level. If P is greater than 0.05, then that means that more than 1 time out of 20, I would see my data by chance alone. So that's too much for me. I can't reject the null hypothesis of no association. The association is not statistically significant at the 0.05 level. A p-value never means that the association is due to chance or chance has been ruled out. It is a likelihood of chance being an explanation for the findings. So back to our example, the p-value was 0.2. And the only thing you need to know at that moment is that the p-value is greater than 0.05. And given that, the null hypothesis is rejected. No, it's not, because it's not less than 0.05. The association is statistically significant. No, it's not, because it's not less than 0.05. The association did not occur by chance. We can never say that. We can never say it's due to chance. We can never say it's not due to chance. The association is compatible with the null hypothesis of no association. For more than 1 out of 20 times, we would see our association that we observed by chance alone. The null hypothesis is compatible then with our findings. And sampling variation is an unlikely explanation for the findings. No, because it's not less than 0.05. Okay, now a couple things about another interpretation. It is suggested that smoking mothers of low birth weight babies would tend to deny such an activity due to feelings of guilt compared to non-smoking mothers of low birth weight babies or smoking mothers of normal weight babies. The important thing here is that it's differential. What is happening in one group, the accuracy of the data, is different than the accuracy of the reported data in the other groups. It's only smoking mothers of low birth weight babies who are denying such an activity. It's not happening in non-smoking mothers of low birth weight babies, and it's not happening in smoking mothers of normal weight babies. It is suggested, so in that example, we're going to say that bias is the explanation. In particular, recall bias, that those who have the outcome tend to recall or report exposures differently than those without the outcome. And what happens if we don't take that into account? Well, remember, let me go back a slide, and it's smoking mothers who deny the exposure that we are worried about. So if they deny it, it's going to look that like mothers of birth weight babies are not smoking as much as they actually are, which in fact then will make smoking not look as bad as it actually is. So it will underestimate the true relative risk. Smoking won't look as bad as it actually is. Now let's do another one. It is also observed that mothers of low birth weight babies tend to be younger than the mothers of normal weight children. And smoking rates are known to be higher in younger women in this population. So we have a factor now that's associated with the exposure, and independent of the exposure is a risk factor for the outcome. And that's a confounder. In the confounder, what it says is you think you're looking at smoking and low birth weight, but you're not. You're looking at smoking and low birth weight through the effect of maternal age. So smokers tend to have another risk factor, which puts them at risk of having a low birth weight child. So the correct answer is confounding. But if this confounder is uncontrolled, in fact, smoking is going to look worse than it actually is, because those who are smoking have another hit. They have a low maternal age, which in itself affects the risk of the outcome of low birth weight. So if I can give you a take-home message on this, the good news there's a lot of good news. The first one is that there's a limited number of necessary concepts when you're thinking about biostatistics, or I also say epidemiology for the boards. They're totally integrated with each other. And that although I gave you some words, prevalence, incidence, lead time bias, there's very few of those words. It's more of a way of thinking than it is memorizing a number of concepts. It's saying that if you're looking at data that are presented to you and you don't think it looks right, you think that there's some other explanation for the data or something else that is not supported by the data given to you, then that's a way of thinking that I'm hoping that we touched on today. And I'd like to urge you to just trust your instincts. If you think that the conclusion is more than is supported by the data, the odds are that you're probably right, because you have the experience that you do in reading the medical literature for all of this time. And if you want any other references, I just threw on a couple that are easy to read, but just cover a lot of the concepts, and might be something at some point if you want an extra book on your bookshelf that would be effective. Thank you all very much.
Thank you so much, Julie. We have 1.5 minutes. Is it okay if I ask you a couple questions that have come in? I just want to say that a couple of people actually said, thank you for this lecture. I needed this refresher. So definitely good, that's nice feedback. Someone asked an interesting question, which was, does this mean that all observational studies are cohort studies?
Oh, absolutely not. Good, very good question. Observational study is any study in which we do not intervene. Okay, so intervention studies are called trials. They are trials. We intervene, we give it to somebody. A case control study, you have people with lung cancer, people without lung cancer, and you ask them whether they chose to smoke in the past. All right, that's observational. A cohort study is one where you ask them whether they smoked or not. Did you or didn't you? I don't have anything to do with it. Did you or did you not smoke? Follow them up into the future. That too is observational. A cross-sectional study where you go out to the community, go to a health fair, and you said, did you smoke? Did you get the outcome? That's observational, because we had nothing to do with it. We're simply recording the answers. So the only time it's not observational is when we, the investigator, play a role in the exposure of the person in the study.
I thought that was a really interesting question. Thank you so much for this wonderful talk and for being with us today.